Thank you very much for this introduction, and I would like to thank the committee for this invitation to talk about anterior sphincteric resection. These are my disclosures. So as we previously said, we know that there is a decrease in the rate of abdominoperineal resection everywhere in Europe, in the US, and in expert center now, it ranged below 15% thanks to centralization, TNT, local excision, and we are talking about distal margin and, of course, intersphincteric resection. The first description of IRS was made by Schissel in 1994 with a description of 34 patients. And as the previous speaker said, we now have a clear consensus with a Delphi published last year in colorectal disease. So intersphincteric resection is a surgical technique for ultra-low rectal cancer, two-phase abdominal and transanal, a resection of the internal sphincter, and an ensued colonal anastomosis. So first of all, it has been clearly, you need to distinguish this from a classic mucosectomy and ensued colonal anastomosis, which is not an intersphincteric resection. When you talk about intersphincteric resection, you can resect the totality of the internal sphincter if you make the incision at the level of the intersphincteric groove. You can resect half or two-thirds of the internal sphincter if you make the incision below the dentate line, and you will resect one-third of the internal sphincter if you make the incision at the level of the dentate line. I won't talk about what is called extended intersphincteric resection, which means that you resect the totality of the internal sphincter and part of the external sphincter. So some word about the technique. First of all, you will decide between APR and intersphincteric resection in the OR after an exam under general anesthesia, and the patient has to be aware that the decision can be taken in the OR between a definitive colostomy or a resection. You can start by the abdominal phase, especially if you have a suspicious of tumoral spreading in the abdomen, if you have a large T4 tumor, or you can start by a transanal approach. As we said, we now have lots of data showing the safety of the TATME approach with excellent R0 resection and a very low local recurrence rate. The difference between making 3-4 centimeter or a complete TATME will be given by the GRECA 11 trial, which compare these two procedures, and the result will be probably presented at the next ESCP meeting. The dissection has been beautifully shown by the last presenter. Briefly, you will make the dissection 1 centimeter below the tumor, removing part of the internal sphincter, and making a dissection in the intersphincteric plane. And of course, you will need to have a completely pathological exam of the specimen. Some key points: you need to close the rectal stem as soon as possible, and I often use a pelvic lavage with betadine to kill the possible tumoral cells in the pelvic and reduce the risk of recurrence. You will extract the specimen either by a phalangeal, suprapubic incision, or transanal, depending on the size, and an ensued colonal anastomosis, most of the time nowadays a straight end-to-end, following the recent randomized study showing that there is no advantage for a G pouch. Systematic stomy, no drainage, thanks to the GRECA 5 trial. And one of the key things important is when you make your ensued anastomosis is to take at least 4 stitches you need to take the external sphincter to reduce as much as possible the risk of rectal prolapse. What are the outcomes of this technique? We had a large review published now 13 years ago, 1,300 patients, only 2 studies from the US. Of course, majority of small tumor, T1 and T2, with 40% of neoadjuvant treatment. So briefly, for the morbidity, it's like a classic LAR, less than 1% mortality, 26% of morbidity, leakage rate in those retrospective studies around 11%, probably more, but no increase in morbidity. What is interesting is, of course, the oncological outcome. And we published 3 years ago a review of 2,500 patients, and you can see 96% of R0 resection, less than 6% of local recurrence, and 88 5 years overall survival. So it is safe in well-selected patients. The problem is, of course, the functional outcome. And the message to your patient is that half of them will be incontinence after an intersphincteric resection. Those are the big numbers, of course, and it is confirmed in this recent paper published 4 years ago. After 2 years, one study looked at the Wechner score. It is in the majority of studies above 8, which is clearly a bad functional outcome. Okay, so the patient has to be aware of this problem. And what are the risk factors to be incontinence after an intersphincteric resection? We published a few years ago that, of course, preoperative radiotherapy increases the risk of being incontinent, and it is confirmed in a large series published a few years ago, when you can see that you have 4 independent risk factors to be incontinent: preoperative radiotherapy, ASA score, metastatic disease, and of course, having leakage after the surgery. And you see the risk of permanent stoma after intersphincteric resection. It ranges between 11 and 19%. So with all in mind, how you select patients to have an intersphincteric resection? First of all, patient selection, as always. And if you have a patient which is already incontinent for the last 4 years, he is not a good candidate to have an intersphincteric resection. You can assess the functional function by clinical exam score. Manometry is not systematic, okay? Age alone is not a contraindication. Pelvic radiotherapy is not a contraindication, but of course, the function of the anastomosis will be worst. Concerning the tumor, as always, you look at the response to neoadjuvant and nowadays TNT. And again, you will decide after the exam, the digital exam under general anesthesia in the operating room. So for the tumor selection, we still need to keep those 2 resection margins that we know. For the distal margin, it has decreased with time, which explains the increase in sphincter preservation. But in the Delphi consensus published in colorectal, there was no clear consensus between 1 centimeter or 5 millimeters of distal margin. I would advocate to keep with an objective of 1 centimeter of distal margin. But you also need to look at the circumferential margin. So it's not only the position of the tumor in the canal, but laterally, and you want to have more than 1 millimeter of CRM. For instance, a T3 tumor can be a good candidate for an intersphincteric resection if the intersphincteric plane is free. And that's why in the Delphi, we proposed to include more accurate TNM with T3 ISP, which means that the tumor invades the intersphincteric plane. So it's a contraindication to make an intersphincteric resection. Same for T4. You can imagine to make an intersphincteric resection in a T4 tumor if the infiltration is above the levator ani, and on the opposite, of course, if the external sphincter is invaded, it's a contraindication. So briefly, you can see here you can see the good indication, but T1 normally will be treated by local excision. Okay, so it keeps T2, T3, and a small T4. Be really careful about making an intersphincteric resection for a T4 tumor. I don't think an extended intersphincteric resection is a good option. The functional result will be probably awful. And you can also discuss to make an intersphincteric resection if you have a T4 invading the bladder, the prostate, the vagina. But even with a good response, probably it's not reasonable. And I would also stress the fact that a total intersphincteric resection probably will give a very bad functional result. So finally, T2 may be a good candidate, but we know that with the local excision, with brachytherapy and everything, there is a very high probability to spare the rectum, and it is already the case in the US when you can see this decrease in the rate of proctectomy thanks to TNT and rectal sparing. So to conclude, intersphincteric resection is a surgical technique just to gain a distal margin by resecting part of the internal sphincter. If you make the incision at the dentate line, you will resect part of the internal sphincter. Below, you will resect 2/3 of the internal sphincter. The decision will be taken in the theater. You will make an ensued coronal anastomosis, probably straight. Similar outcome for the morbidity, but a worse functional result, and a lot of contraindication, pre-op incontinence, infiltration of the intersphincteric space or the external sphincter, and a huge T4B or bad response to neoadjuvant treatment. So the best indication is a T2, T3 after neoadjuvant treatment that require a partial ISR. But again, what will become those indications with the sparing technique thanks to TNT? Thank you very much for your attention.